So that's the quick run through. Remember when now that we're going to open it up for questions, we're audio recording the session. So when you have a question, it would be good if you could introduce yourself briefly. We'll post the recording on the RISE website. And just a reminder, we're not the right ones to answer policy questions. You can direct those to the ministry, but our ministry colleagues are listening in case your questions or comments give them ideas for things that they can do to better support Ontario health teams. So questions, comments. Carrie, no one online yet with the question. So what about folks in the room? Yep, Maureen.
Hi, Maureen Markle-Reed from School of Nursing.
Yeah, and sorry, Maureen, can I just interrupt just to reassure everybody there's mics in the room, so our colleagues online will let us know if they're not working, but when you speak, it should be hearable by our colleagues online.
I just have a question for clarification. At the beginning, you talked about areas for improvement.
Yeah.
Were those identified by the ministry or by the teams themselves?
They are us listening to what we've heard the ministry say, but the ministry has never come out and said, here are the strengths, here are the opportunities for improvement. It's just we sit in on every webinar, we go to every talk, and we're listening for that. Now that we've been out in most communities, so we've been to now 5 communities, and we're speaking to teams in a much more direct way, what we heard initially is very consistent with what we're hearing them say. And when we present these high-level themes, people are going, yeah, that's kind of what we figured, or in the case of teams in development, what we were told. Teams invited to full application got no feedback. It's only the teams in development that got some feedback, so that's where we're getting this.
So the needs assessment was done informally through those discussions, not in a formal way. So,
yeah.
Okay, because I just wondered, I don't know what your topics are for those 8 sessions, but just wondering how you identified those challenge areas and the topics, content areas that you're going to be addressing.
In the webinar?
Yeah.
So it's iteratively adjusted. Like we originally had a conception of what we were going to deal with in the webinars, but now having spoken to because in each community we've often had around 100 people, that are team members. So we're now at about 500 people that we've interacted with. So from most teams across the province. So we have a pretty good sense of what are some of the really pragmatic issues. So Carrie and I were just talking about what we're thinking about doing on Monday. So we're just going to road test that again this afternoon with some colleagues just to make sure that makes sense and then roll it out. So our original intent was more kind of pragmatic, here's how to do X. But it turns out that there are a lot of process issues, like partnerships, that people are really grappling with, and they find it very helpful to hear different models. One example would be a lot of people didn't invite municipal government in round 1, but now they're thinking, wow, municipal government oversees housing and social services. Municipal government can think about these bigger determinants of health where we can intervene at the level of the whole population. They have ambulance services. There's many reasons to bring them to the table, so the idea would be introduce the idea and then have a municipal government leader. So we've invited Paul Johnson, he happens to be from Hamilton, to speak to it because he's very articulate about why municipal government can bring a lot to the table. Initially, that budget is not part of the Ontario Health Team, and there is no explicit statement that it ever will be. So the budget going to the Ontario Health Team is only the health budget, but why would you not want the person sitting there who brings housing and social services, because they're going to be such a key part of the solution.
Right, that makes total sense.
Okay, Mark?
Mark Levine from the Cancer Center. I have 2 questions, if I may. First is at a higher level, there was, and I think there still is, a provincial cancer agency. And despite it being absorbed into some super agency, I actually think having a provincial agency is a good thing. So how are they being engaged? At a local level or at a provincial level or at both?
Well, I guess what I'd say initially is that teams are very focused on the more general services, the kind of home care, primary care, general hospital care, and the most highly specialized care, which I think people would tend to put cancer into for now, is not seen as part of this. There are obviously conversations happening at the high level, which is way beyond my pay grade. I'm not aware of where those conversations are. That will eventually sort itself out, and then over time it will become clear about how Ontario Health Teams will then kind of link up to those. Another example would be mental health. So the government announced a Centre for Excellence in Mental Health. That will at some point appear and then be a key resource to the teams, but the intersections haven't been worked out. So people are focused for now on home and community care, primary care, and more general specialty or hospital care. And then in future, the conversations will start to happen with cancer and other things.
And I'm particularly interested in the digital health side.
Yeah.
And knowing our ecosystem
Yeah.
in Hamilton,
Yeah.
wow, we have a hell of a long way to go.
Yeah.
So how does one find out who, yes, there's multiple players,
Yeah.
but how does one find out who the people are to speak to find out more information?
Well, digital health is an area that's going to become much more transparent, either today, tomorrow, or next week. So the ministry has been working for a long time on what's called the Digital Health Playbook that articulates the vision for where we need to be in digital health. There are 4 policy documents that are part of that lay out how we need to be approaching this in future, and that includes things like statements about how it's important that locally we sort out solutions like a patient portal that's available to everybody, while at the same time making sure that all of these things at the end of the day need to link up. You can't end up on a little Hamilton digital ecosystem that doesn't communicate to others. And then the third piece is the ministry's current sense of what all the digital health assets are that we need to be leveraging. So we're always, if someone's got a solution that's almost there, we should be building on it and scaling it out rather than starting from scratch. So that suite of documents start to lay the groundwork, identifies very clear focal points, and the message is, if you have ideas to help us get farther faster, send them in. And they're now trying to be much more agile in how they take us forward. So it happens that we're introducing Ontario Health Teams at the same time as the government is taking us from here in digital health to aspirationally to here.
So stay tuned.
Stay tuned, and we thought it was going to be this week, and maybe it'll get pushed to next week, but it's imminent. Carrie.
Solo practicing primary care physicians are not yet engaged in the process and are unwilling to do so. What strategies do you suggest?
Yeah, so, when I covered what our best guess is with the, primary care leadership piece. So, it comes back to there are very well-connected associations that are working with individuals. The OMA often, has a particular way into certain constituencies among physicians. Other groups, if you're in a team, it might be the Association of Family Health Teams of Ontario. So that's a key group to help providers over time understand why this might be helpful. What people need to focus on, I think, is trying to understand from a primary care provider's perspective what's in it for them. And one of the things is, right now, a lot of primary care providers feel like they're accountable for everything. But under this model, there will increasingly be a large group of people that are trying to figure out how do we build a package of supports around these patients so it doesn't all fall to the primary care providers. So there are clear wins for docs, but they're also nervous about entering into something that might transform how they deliver care. So those associations are key, and then nothing's going to substitute for primary care leaders. So we've seen in many communities primary care docs stand up and say, I'm going to take this on. And I don't want to keep coming back to Hamilton, but I could give examples from Hamilton about how we're seeing primary care docs stand up and commit to, over time, work with the diverse constituencies of primary care providers in their communities. Hamilton's life is made a bit easier by having such a high proportion of the provider community in a family health team, but at the end of the day, every doctor still will have to make an individual choice about whether he or she joins, independent of what the family health team decides. So it's a long journey, but I think if we focus on trying to understand what primary care providers' concerns are and try to understand what changes would make their life easier, we're more likely to be successful in engaging them. Other questions or comments? Yeah?
I have a follow-on question. So I guess I have the lens of a healthcare system innovator. So I have a startup called Empower Health, we built a directory called IMSIC.data National that maintains up-to-date information about the facilities. And so a follow-on question related to primary care is, are the OHTs provided with information, or do they have information about who within their geographies or communities offer primary care? So are they aware of all the solo practitioners within that region?
Yeah, so my understanding is yes, but, you know, and they'll have it through different ways, but, you know, so in Hamilton, 2 family health teams get you to something like 60% of the population, and then they know what the walk-in clinics, which the walk-in clinics are. So it's most people have a pretty good sense of
Do
who
you
they
know if
are.
that comes from the ministry or the LIN?
I would have guessed
In
that.
terms of data quality, I've noticed that there are some gaps.
Sure, yeah.
I'm wondering.
Well, my hope would be they'd be looking at multiple sources. So many of the docs know who a lot of them are. They can go to the health line to get a sense of who some of them are. That's not always fully up to date, but they try very hard. So there'd be multiple ways to try and get it. But this is going to be key for them in future to always know if a new walk-in clinic pops up, they need to know and start to figure out how to engage that group and engage them in the Ontario Health Team.
Yeah, okay, and I'm thinking opportunities for other supporters, those that do have that information,
Yeah.
to make it known to Ontario Health Teams that it is available.
Absolutely, yeah, no, absolutely, good point, sure. Other questions or comments? It's like an undergrad class. I always say I'm comfortable with silence, so I'll wait you out for a few minutes to see if there's any other things people want to ask. And Carrie, you'll interrupt if anything comes in online.
Yes.
Oh, there we go. 2 people felt so
So I represent one of the LIN-funded home care agencies.
great.
And in some of the documents and the ministry webinar, there's a commentary around organizations should only be part of one OHT, and yet that may not be the case for some types of organizations.
Yeah, no, absolutely. I wouldn't, I mean, we see some partners that are on, you know, 10, 15 applications because they deliver services in all of them. So yeah, I would not worry about that. I think what will end up happening over time is as the people come to understand these naturally occurring utilization referral networks, and as people work out, you know, which the population segments are, and so then providers that are active in multiple parts of the province are going to have to stand back and say, from a business perspective, where do we want to be active? And it could be truly our province-wide, and you're working with every single Ontario Health Team, or you might make a decision you're working with 4. So I think this will probably cause a lot of organizations to reassess which partners are the best match to them going forward, but I've certainly never heard any guidance that would suggest that people shouldn't be working across multiple health teams. And there are many, many organizations that are, because they have a regional and sometimes a province-wide focus. I think one of the challenges that we want to cover in the webinar coming up is how do we, it's hard for organizations to do that, right? So we've talked to a lot of folks that say, we're active in, you know, our services right now would overlap with 4 Ontario Health Teams. Each team is having meetings every time they turn around trying to meet the October 9th deadline. We can't field senior executives to every single meeting for all 4 health teams, let alone some of them are involved in 15, 20. So there's a lot of issues that people are struggling with about how do they have a voice at the table, while at the same time not losing all of their executive ranks while they still have to keep running their home organization. So we've seen some interesting models where, you know, teams have developed this kind of more distributed approach where different people are tackling different things, and they have briefings once a week to bring everybody back up to speed, and trying to realize that you don't need to be at every meeting, but you need to make sure you're at the meetings where your voice is likely to be particularly helpful in shaping the conversation. But it's not easy. I think we've heard a lot of providers really struggling with how to staff this because of how many meetings are happening in so many communities where they currently provide services. Mike?
Yeah, in some of the conversations I've been a part of, one of the areas that you mentioned around where there's a lack of clarity is around governance, but the other seems to be funding flows. So, like, is the funding my sense is that the funding is going to continue to go to organizations the way it is now, but is the sense that it's going to shift to one central funding flow to an OHT and then it gets distributed within it to partners and
Yeah, so-
sense of clarity of how that's going to...
Yeah, so everything I've read suggests the funding does not change for the foreseeable future. At some point, the teams that get through this stage will then go through a process, and eventually they will become what's known as designated Ontario Health Teams. And then what is in the available information is they will eventually receive a single funding envelope. The terms of that haven't been kind of laid out. You could guess what some of the attributes would be some per capita adjusted for key kind of variables, but that has not been specified. But in the long run, that would be the transition. And then, hopefully by then, teams have the collaborative governance model in place where they're all agreed on what they're trying to do as a team. They're all agreed about what each partner's contributions to that are. And so when the funding starts to flow into the central model, it shouldn't come as a surprise about why it goes to different partners in different allocations. It's because they've already worked through the pieces about who's going to do what. Yep, Carrie?
I have two questions from online. The first is it your sense that multiple OHTs will coalesce into regional systems?
I don't have any reason to believe that. I mean, the way that the attribution model is currently working is that, there are these naturally occurring networks. The government doesn't want to disrupt the way that individuals are seeking care or providers are referring care. We know that there's somewhere between 85 and 90 of these naturally occurring networks. And so those are logical groupings. If someone wanted to make a case of we're going to combine two, presumably that would be possible. I haven't heard that that would be in any way incentivized or emphasized or actively discouraged. I think now is the time where people went in the self-assessment with a sense of this is the community. They're now seeing maps that show them this is the community, and they're more focused on that closer to home conversation. But over time, it could be that it makes a lot of sense to think about certain of these naturally occurring clusters to come together, but I've not heard anybody say one way or the other whether that would be good or bad or encouraged or not.
The second question is, care coordinators have been kept within our LIMS. A lot of heavy lifting will have to be done by care coordinators. How do we shake and move from the LIMS?
Well, I think that Appendix A of the full application specifically says, where the ministry is actively thinking about what the future of home care is going to be. Do you have thoughts about what would be optimal from the perspective of your team? So the government's essentially doing a consultation process through the full application to hear what folks think. What I've often said to groups informally is, if you have the time and energy to think about that and give the government guidance, great, spend a lot of time on Appendix A. But what's critical for you is to think for our year one priority populations, what would be optimal? And if it turns out that having care coordinators moved into family health teams or some other configuration would be optimal, then great, but then signal that to the government in Appendix A. So, Appendix A is there for people who want to spend as much time rethinking home care as possible, but I would turn it around and say, think about what's going to be most helpful to you pragmatically with your year one priority populations, and then distill the implications and put that in Appendix A. And did you say there were two questions?
That was it.
Okay, sorry, I lost track. Yeah.
What do you mean by naturally occurring teams?
So what the government has done is they built on an analysis done by what used to be called the Institute for Clinical Evaluative Sciences, it's now ICES, and they looked at these naturally occurring networks. So they looked to see where people are currently rostered. On average across the province, you can allocate 82% of us based on where we are rostered with the primary care physician. Then the next 16% comes from people who are not part of a rostered practice, but they've chosen to seek care from a certain primary care provider. So if I've gone 3 times to this doctor and once to this one, I'm allocated to this one. So the attributed population is that group of people that go to those primary care physicians. Then the hospitals get linked. So if I'm a primary care physician and most of my patients go to St. Joe's, then St. Joe's becomes part of that utilization and referral network. So you end up with understanding where people are going for primary care and where they're typically being referred for secondary care. And it's specifically focused on referrals for chronic conditions. So it's not cancer care, for example, the highly specialized stuff that is likely to be treated differently under this model. Make sense?
Yeah.
Okay, any final comments before we wrap up?